Andrew Witty, CEO of United Health Group, recently penned a New York Times essay that read like a biting critique of an inefficient U.S. healthcare system, making Witty appear oddly unaware that UHG is the biggest player driving that system, and perhaps some of those very inefficiencies. The top 6 U.S. healthcare insurance carriers based on 2024 revenues are as follows. United Health Group, $400 billion, up 8%. Elevance Health, formerly Anthem, $175 billion, up 3%. CVS Health Aetna, $400 billion, up 6%. Cigna, $247 billion, up 27%. Kaiser Permanente, $114 billion, up 13%. Centene Corporation, $162 billion, up 8%. Total revenue across the top 6 carriers amounts to a whopping $1.5 trillion. With minor exception, only a tiny fraction of that staggering total goes toward what any of us would consider care to patients, where care is defined as physicians, nurses, staffing, diagnostic testing, or any variety of hospital services or drug prescriptions that aid in the treatment of patient health conditions. But pay careful attention here. Nearly 100% of that $1.5 trillion is consumed by a bureaucratic behemoth of paper pushers whose function is solely to administer payments to providers. They are not providing any of the care, they are simply billing it. There is very little that UHG and the other national carriers do today that cannot be accomplished at a fraction of the cost, and far more effectively and efficiently with modern payment technologies. That, however, would not generate such a positive outcome for their shareholders under the current healthcare business model. Why is that? Well, let's first look at what should be expected of these insurance carriers and plan administrators, and then get back to Andrew Witty later. In today's healthcare landscape, the role of administrators is, well, more critical than ever. They are expected to manage complex systems, ensure compliance with regulations, and most importantly, advocate for the well-being of employees and their families. These expectations are, honestly, not just about administrative tasks, but about making a real impact on people's lives. In theory, there are 3 expectations when an employer hires a third-party administrator. These expectations are fundamental to ensuring that the healthcare system operates smoothly and effectively for everyone involved. The first expectation is for that administrator to effectively advocate for employees and their families in navigating their care journeys while preserving the anonymity of the employee and their families. This means providing support, guidance, and, a sense of security as they move through the often confusing healthcare maze. The second expectation is for the administrator to avail the employer of highly competitive negotiated rates to ensure that employees and families are receiving high-quality care at a fair price. And finally, there's an expectation that the administrator has the requisite skills and internal control environment to not only pay bills accurately, but only for eligible participants and at competitive market rates. Let's start with the advocacy component. We here at FinHealth have first-hand witnessed self-funded employers whose individual members can rack up as many as over 100 healthcare encounters annually. This would represent employees and family members whose lives are interrupted twice a week every week with required encounters within our health system. Why? We have no idea, because employers and providers lack a compassionate care system component that would monitor and track why these visits even occur in order to better advocate for members. Is it improper treatment? Could it be non-adherence to medication, or worse yet, medication that is causing more harm than good? Is it low-value care or even high-value care propagated for no other reason than to feed the machine? Even in the tragic case of multiple suicide attempts by an individual, we do not have in place compassionate intervention for that person, other than treating the resulting physical health effects. We do have this information readily available to intercede and advocate for the most vulnerable members of our population. We must use it to promote their health. Let us look at the second expectation: quality care at a fair price. Negotiating provider rates for the best affordable care. We routinely see healthcare bills improperly upcoded to unconscionable levels, particularly on ER bills. subjecting members to huge medical debt, personal bankruptcy, or stifling monthly payments spread over the next few years. Hospitals might upcode because many of their services require overnight stays, also called inpatient treatment, and inpatient costs are paid using predetermined rates according to their diagnosis-related group. And emergency care is just that, emergency care. No one plans on it. Uninsured individuals, those with heightened anxiety due to previous medical trauma, the need for speed and ease of use, as well as complex or unavailable primary care, all play into the overutilization of emergency care departments for clinically unnecessary reasons. We need controls in place that encourage members to seek alternative care. How about a better relationship with a primary care doctor? How about staying on top of medications? Each year, over 3 million people are admitted to ER departments due to dizziness and falls related to medications. It is estimated that 30 to 70% of ER visits are avoidable, so the education of members is key to cost savings. Internal controls and payment integrity are crucial elements in managing healthcare costs effectively. Ensuring that payments are accurate and only for eligible members at competitive market rates is essential. That brings us to our third expectation. Your administrator needs the skills and internal controls to pay bills accurately, and only for eligible members at those competitive market rates. We regularly witness a serious lack of internal controls in the payment process across all carriers, including shockers like this one. More than 10 eligible covered individuals living at a single home address? Is no one checking member eligibility? We have also witnessed the payment of outrageously inflated claims like $188,000 for a Tylenol infusion or a $25,000 CT scan, not just one at that price, but 4 of them. A reasonable request from any employer is that an administrator would verify provider bills before the money leaves the health plan. Alarmingly, none of the national carriers mentioned at the start of this article would receive a passing grade in any of the 3 expectations above. The level of internal controls for the national carriers is virtually non-existent. While there are plenty of people and processes and even an internal department known as payment integrity, the system lacks an effective and independent level of monitoring that would meet the standard for an internal control for self-funded employers. A hospital bill of $500,000 undergoes no verification to ensure the services were delivered, were clinically appropriate, or were billed at a reasonable and accurate rate. National carriers rely extensively on ancient technology to process healthcare claims in 2025. Before entering healthcare 10 years ago, I spent 25 years working with elite employers in implementing and optimizing real-time monitoring of disbursement systems. For some odd reason, these state-of-the-art disbursement systems, like what we see with our personal credit cards today, have not made their way into healthcare. Think of the real-time texts you receive relative to your personal spending, notifying you immediately of payments that are questionable or duplicative. Conversely, in healthcare, claims are processed using technology developed in COBOL, circa 1960. Little to no money has been invested to modernize this structure because it would result in less fees and lower revenue for the national carriers. Why would they upgrade? Imagine a system that rewards the plan administrators exponentially more money when they process a payment incorrectly than processing the payment correctly the first time. The only way for a healthcare administrator to grow their revenue to reward shareholders is to increase the size of the pie, due in great part to the medical loss ratio or MLR. In 2010, the Obama administration issued a regulation implementing this medical loss ratio provision of the Affordable Care Act. Insurance companies would be required to spend 80 to 85% of premium dollars on medical care and healthcare quality improvement, rather than on administrative costs. Sounds like a good idea, right? While that law was well-intentioned, it continues to drive perverse behavior and tremendous inefficiencies in healthcare. Insurers stand to make more money if total overall spending increases because it becomes easier to meet that 80% threshold with inflated medical care costs. If medical expenses rise, insurers can justify charging higher premiums while still meeting MLR requirements. Since administrative costs are capped, insurance carriers have less incentive to invest in operational efficiencies, fraud prevention, or innovations that could reduce healthcare costs over time. What drives good health are investments in affordable and accessible housing, nutritious food, transportation, and social support networks. But investments in social drivers of health, or SDOH, must now be classified as administrative costs rather than medical costs, making it harder to meet the 80% threshold. Now back to Andrew Witty's 600-word essay in the New York Times. He has received such incredible blowback from the American people, business leaders, and healthcare system workers nationwide. Does he not realize that UHG leads the pack and made $400 billion in 2024? Last year in 2023, UHG made $372 billion in revenues, delivering a cool $22 billion in profit from what he calls a confusing, complex, and costly industry. In related news, UHG spent more than $16.6 million in 2024 just lobbying Congress on healthcare-related issues. This confusing system also rewarded Witty with a $23.5 million salary for himself in 2023. Is Andrew Witty throwing up a smokescreen to obfuscate, deliberately making the whole healthcare industry seem difficult to understand? Or is he just trying to defend UHG by laying the blame across other players in the healthcare industry? That is for the American people to decide. Witty also mentioned in his essay that he and United Health are willing to partner with anyone to find ways to provide high-quality care at a lower cost. He says he wants to build a healthcare system that works better for everyone. No one would ever design a system like the one we have. Maybe he will partner with us here at FinHealth to find ways to provide those lower costs and better care. But from our perspective, over the last 10 years we have been lectured, threatened, bullied, and lied to in the pursuit of cleaning up and simplifying the healthcare payment industry. We have witnessed countless instances of fraud, waste, and abuse. Certainly, someone must be benefiting from this confusing, complex, and costly industry, for it seems no one is stepping up to fix it. And why should they? For why would they kill the goose that laid the golden egg? Today, we are putting forth this important reflection to all our self-funded employers out there in America. If your plan administrator cannot 1. Advocate for your employees and families, 2. Ensure high-quality care at a fair price, and 3. Design internal controls to accurately pay provider bills at competitive negotiated rates, then why did you ever hire that plan administrator in the first place? If you are a privately funded healthcare plan and you need our help navigating the healthcare system and saving your plan millions of dollars, please contact us at sales@finhealth.com.